All right, we can get started now. Um, we're going to start with Dr. McNamara. He has a flight to catch, so I think we can start with him. He's going to speak to us about acute arterial thrombosis during lower extremity intervention, and then we'll go to the live case. Welcome.
Thank you very much. And thank you very much, Jaafer, for including me. It's a very august group, as always. And my topic today will be a complication which probably is pretty rare, having to do with retrograde tibial axis, but I don't know about the rest of you. I don't do that much of that. And it always struck me as a little bit odd that everybody who presents makes it sound like, maybe not deliberately, but makes it sound like there's never any complications, which I bet can't be true. So I just want to share with you a complication that I experienced and what I wound up doing about it, and I think it's a valuable tool that we wound up using. I'm not quite sure I know how to advance this. That's not it. Here we go. This is a 73-year-old man, former smoker, presented with a cool foot on physical exam, complained of rest pain and 1/4 block claudication, had a very low ABI in the critical limb ischemia category, and he had rest pain. Weak femoral pulse, but a loud bruit, no distal pulses. We accessed him from his right side. It was his left side symptomatic, saw that he had a very large, volume-wise, and heavily calcified eccentric common femoral artery stenosis. I'm a big believer in the cutting balloon, and so we cut it and got a somewhat reasonable response, but then stented it. And we left him with a wide open profunda and SFA down to his popliteal. Didn't treat the popliteal. It was also a large clot volume, heavily calcified. My reasoning was that it would probably require a stent, which these days, in my experience, more often than not requires repeated intervention. So I wanted to give him a trial with improved inflow into both his profunda and his SFA. His foot did become warm. His walking distance improved. And he had decreased but still present rest pain. So about 3 months later, after I thought what he and I and his family thought was an adequate trial, we approached him again, same way, right femoral access, and tried from an antegrade approach, as I think most people would, to cross the occlusion. And the crosser, which has had a great deal of success, didn't work in this instance. We don't have that many crossing devices in our laboratory, and that's one, and we tried that. It went extra luminal, and probably because it's heavily calcified. The guide wire and catheter traversals were tried. There was extra intimal, and we were unable to re-enter. So we looked at him, as you'll see, downstream, and he had a very nice anterior tibial artery. We accessed that rather readily, gave intra-arterial heparin, papaver, nitroglycerin, and this just are some of the highlights. You can see that 3 months after we put the stent in the common femoral, which is controversial, I would do it because I think it's a reasonable approach for a lot of reasons. That's a separate discussion. It was still at 3 months widely patent, and you'll get a look at it at a year. It was still open nicely. At any rate, downstream he had, as mentioned, you can't tell it on the subtractions, but a very heavily calcified occlusion. And we tried their crosser, which is a little difficult to see on the slides, went extra intimal, and we did with just a guide wire and catheter, managed to create partial traversal. The arrows are to try to show you the size, volume of this clot, which was, as you can see on the image on your left, very heavily calcified. And we progressed on down there trying to dilate the tract, seeing if that would assist us. Sometimes, in our experience, that will, but the guide wire would not re-enter. But we did leave a large target where we had done the angioplasty for potential re-entry from a retrograde approach. Look downstream, and as you can see, he has a very nice anterior tibial artery. We access low so as to reduce the chance of compartment syndrome if he had bleeding post-procedure. And recanalized from below, angioplasty, took a look, and oh my goodness, what happened to our anterior tibial? Well, is that really occluded, or is that just spasm? So we took a look, and no, it's actually really occluded. Well, there's lots of ways to try to treat fresh clot, one of which is angioplasty. We had had a small wire in place, and so we put in an even smaller one, put a coronary balloon system in, and we did diminish the volume of the thrombus some, and we thought we would be addressing spasm if there was some, or dissection, which we didn't think was likely, but maybe. So he still has the occlusion after having done that simple approach, more heparin, more nitro. And so then we did what so much of lysis is not done anymore. But one thing we had a lot of experience with initially, which actually sponsored a large trial, was the use of so-called brand name Riopro abciximab. And so we gave a 20 milligrams in divided dosages in a 5 ml volume, so 2.5 cc's to begin with, through a catheter that myself and Andy Craig managed to get our names on. It works nicely. Goes through the forefront sheath, just gave a gentle but pulsed dose of 10 milligrams, and 5 minutes later gave another, and then 10 minutes after that did a repeat angio. And as far as you can tell, has got no real clot left, and what's down below there is just a sheath filling up the lumen. So that was nice, and then we thought, well, maybe we should take that sheath out of there, which a lot of people do earlier on than we had, and so maybe that is a lesson. It does have, unfortunately now, a little bit of a stenosis upstream. I'm not sure that, at any rate, I don't seem to be able to move the pointer. Anyway, you can see the little stenosis, which we didn't know if that was really a fixed lesion or, oh, thank you, or a spasm. At any rate, we went ahead, finished, wound up putting in a Supera, which has the reputation of claim of being a great device for this area, and we finished up, I beg your pardon. Meant to show you downstream. He was open, as you would expect, at the end, and his anterior tibial was nicely patent. But 9 months later, he came back having he was a very stoical fellow, but he was having a claudication, and he was having maybe rest pain at night. His wife kept saying he was, he kept saying he wasn't. At any rate, he dropped his ABI quite a lot, and he'd had a palpable dorsalis pedis and posterior tibial pulse up until about a month or so before this. So we looked at him again, and he's got in-stent restenosis, which happens. And so we angioplasty. It looked pretty good in the RAO projection, LAO no. And so what do you do? I think, as an editorial remark, I think the best thing would be to really laser it, and then probably use a drug-coated balloon. But that takes time. And or Dr. Matarjami might use a Viabon. At any rate, what we chose to do is put a drug-eluting stent in, still some stenosis where the red arrow is. So just intuition, we thought maybe for the long term, this guy's already had 3 procedures, we would use a drug-coated balloon and see what that would do long term. Gave a nice initial result. And it's interesting that in the anterior tibia, which remains open, that he has these stenoses. It's interesting, is that just because we did a little more in there than the usual retrograde, or is that maybe an intrinsic problem with traversing the intima too much in these vessels? It's just shared experience, not sure exactly what to make of it. I think it's a guide wire, though, because it's actually proximal. Those areas of stenosis are proximal to the puncture site. So what to do if this occurs? I think we have a number of choices. One's the angiojet. It takes time to set it up. It's not a fortune, but it is an additional bit of money. The abciximab is pretty cheap now, or just accept it as an occlusion. But, you know, what's to tell you that you won't want to reaccess his anterior tibial again if you have a thrombus there, or whatever tibial vessel you're in. And so we'd always like to not give up any vessels. Also, his outflow would be worse, which I think all of us would agree decreases patency in stents and or bypass grafts. And bypass grafts, as a topic, he would be a poorer candidate for a future bypass, as one less tibial. Post-procedure anticoagulation, relying on their own endogenous lytic system. Not sure, nobody's ever going to have 100 cases to tell you what that's like, but I think this was more likely to work. Fresh clot has a good deal of turnover. Fibrin platelet adherence, platelet sites are more permanently bound by abciximab than by fibrin, so as the fibrin washes away, which it does normally, which is why you have these fibrin degradation products floating around the bloodstream, the abciximab will glom onto those sites and it won't let go, so the fibrin can't get back at them. And at least that's the the mechanical explanation. So thank you very much for sharing, letting me share this case with you. I think it's something to have in mind as we're doing these cases. Thanks very much.
Hi, Miguel. Can you hear us?
No. Yes.
All right.
Hi, how are
Perfect.
you?
Good.
Fantastic. Thanks for having us back, guys. I'm sorry I was a little pushy to get back on. I was trying to get them to go because we have another patient and turnaround
Sorry.
time and so on and so forth. So anyhow, we're here. Thank you for having us. A big shout out to Jaafer and the team of people putting this meeting together for doing a fantastic job. Like I said before, we're here with Rob, our technician. We're with Dr. Fabella, an anesthesiologist. And now we have Julie in the nursing, and the tech is Ed Salazar. Luis Leon is my partner. He's helping me with these two cases. Later on, Pakanowski, my other partner, will be helping us. So just a side story to share with you guys. It's been a big experience in America, and I've learned a lot of things amongst the thing that's called anger management when you're in a lab and you become very passionate and saying things. So they have actually, my staff made this sign, so when I need to say something, I can't really say it very verbally, so I just get to use my sign, which just means I can't say it, I can just put it. And then if I'm really, really mad, this is sterile, by the way, I'm gonna actually produce them, so I can send them to all of your labs. I can use that one. So anyways, that said, now to the serious part, let's talk about this patient. Let's go to the first slide, Chris, and see the presentation, case number 2. And this is a 64-year-old gentleman who has right lower extremity lifestyle limiting claudication. He actually had bilateral. He came to us about a month ago. He has a Rutherford class 3, and when we look at wound, ischemia, and foot infection, there's no wound, there's no infection, but there's certainly a good amount of ischemia in this patient. He had contralateral endovascular left SFA therapy 4 weeks ago for a fairly tight, above 90% stenosis into the adductors canal. And in further evaluation of that right lower extremity, he has ABI, which was 0.6 baseline, drops to 0.4. With exercise, he gets immediate calf cramping, and he can't walk further than 30 to 50 feet. Moreover, he has a right lower extremity duplex that shows greater than 80% distal SFA stenosis with velocities within the 3 to 4 millimeters per second. Next, let me share a little bit of what some of the stuff we saw last time. As you can see, that subtotal occlusion of that distal SFA in a fairly diseased distal SFA in him last time. And I want to bring it because I know that we've been talking a lot about restenosis and how can we deal with this. Well, one of the trials that we're involved in, and we're going to show you some of what we had, is we've been actually doing the dance trial. Dance trial uses a device called the bullfrog. Next slide. That device, as you can see it on this screen, and I understand that Dr. Lou Lopez is going to walk you guys through some of his personal experience, but we're really interested in this device and have had some good results initially. This has a constrained little small perforating needle that when you inflate the balloon, it actually crosses into the adventitia. Well, why would you do this? Well, because a lot of what the discussion has been on the table with drug-coated balloons and so on and so forth is this: how much of this medication potentially goes downstream in a patient that has critical limb ischemia and you're trying to heal them. And really, at the end of the day, what you're trying to do is get to those adventitial and medial layers where those quiescent cells lie that upon barotrauma and inflammation will grow into intimal hyperplasia. So next image, and click one next also, Chris. So you can see this small little video as it starts inflating, it pokes through the arterial wall, and then that blue contrast there is just a way to show what we would be injecting. And in this particular trial, in this particular study, we're doing dexamethasone. We usually use about 32 milligrams of dexamethasone in about a 10 cc syringe, and depending on how many pokes you have to do to cover a lesion, then that could be up to a maximum of 32 milligrams of dexa. Next. So let me show you how that looks. Is we actually we put a little 2 mLs of contrast into that solution, and allows us to actually see how that circumferential distribution of the medication is very clear. So click next, next, next. And you can see those 4 spots. There's one more, I think, Chris. Nope, then go back, sorry about that. 3, there you go. So you can see those 1, 2, 3, 4, 5 spots where there was an ejection. That does not relate to extravasation, or at least in our experience hasn't been related. Certainly the needle isn't super robust, so it has to do also with the calcification and the amount of penetration that you can get. But sometimes you can shy a little bit away from a calcified plaque, still get adequate penetration, and then the drug will diffuse retrogradely and antegradely to wherever that injection site is done. Next. This is a final shot of that screen, and I apologize for some of the pixeling there. I took it with my iPhone last night at midnight. Anyways, I think that's the one. Go next. Our preoperative plan was to do vessel preparation in this gentleman. We don't like enrolling our patients with 2 legs into the same trial. We just want to look at how his left lower extremity does, and we would just do standard of care of his right lower extremity. And like I said on the initial duplex, there's some high degree stenoses of the distal SFA. Now that we've done some images, we might change our plan because we don't feel that some of those lesions are that tight. And we'd like to actually hear the panel discussion regarding some of the options that we have here. So let's go with the first image on our angio. Chris, thank you. So as you see, this is just a fairly straightforward antegrade stick. You see how that's a fairly diseased from the proximal mid and distal SFA, more pronounced into that distal SFA. That's where they found that 3 to 4 meters per second lesion. Go next. The next one, Ed. That's more of that distal, more diseased area with some collaterals that show you that there is something going on hemodynamically. And then next one, please, Ed. You see how there is also some tightness regarding the popliteal, and then a fairly tight subtotal, also proximal anterior tibial artery. Pretty much the only vessel that goes down to the foot. Keep going. There's then a anterior tibial tight lesion right there. And then the rest of the AT actually looks fairly benign looking. The perineal's there, the posterior tibial, of course, is out. And then next, last but not least, always important doing a distal runoff to see what's really his main vessels. On physical exam, he has no pulses, clearly due to the tandem effect of all these 50 to 80% stenoses altogether. So I'll be honest, it was actually Luis, he hadn't seen this angio before, who made a point about the necessity or not to deal with tibial disease in somebody that has short distance claudication. So I don't know, Luis, your thoughts here before we ask the panel what their thoughts are.
I'm sure this is going to be controversial, but if this were my patient and my decision, I would just treat that SFA, diffuse disease of the distal half, and the popliteal severe lesion, and leave the tibial alone, since obviously we're doing this for claudication, severe claudication, and not for critical ischemia. I'm sure there's going to be some disagreement. I have visited other surgeons in other places. I remember being called a coward American, even though I was not an American at that time. I am now. But I was told a coward American because when the surgeon asked me if I will treat that AT in a precise similar case with claudication, I said no. And he actually just treated with no problems. I'm sure the chances of success will be very high and close to 100%, but it's not 100% in my opinion. So for a little chance of creating a dissection or a perforation with a mishap during the therapy and converting this patient from non-critical to critical, that is my point behind not treating the tibials and just addressing the SFA and popliteal disease. But that's just my point. I was curious to hear how many people in the audience will actually treat both segments as opposed to just the femoral popliteal segment.
So I'm just going to start advancing some of our therapy catheters, and just before we open some of that discussion, because I'm also very interested in what you guys would have to say, we have opted for a focal force balloon as means to vessel preparate, but honestly, we are not set at this point absolutely in dropping a stent into this fairly diffuse lesion where you don't really have that specific long, tight lesion that you would know is going to respond negatively. And moreover, I honestly think to a certain extent, we went from balloon angioplasty to the huge hype of DCBs, and we kind of ran over a little bit over focal force balloons like VascuTrack or the Angiosculpt, which has unfortunately not been met with the same, let's say, push or thrill by the industry, and at the same time by ourselves too. We haven't really done a whole lot of research as to slow, controlled balloon angioplasty, limiting dissections, and seeing how they do. We saw it in the DCB branch of the Lutonix trial. I mean, those slow, really controlled balloon angioplasties do work well, and I think it's time for us to re-explore that. But before we go into the PTA and balloon angioplasty technique, I'd really like your thoughts on SFA pop versus are we going to touch the AT or not? Because we're at least 50-50 in that
Miguel.
situation.
Miguel,
Yes.
this is Eric.
Hey, could you show me the proximal SFA?
Can you hear me?
Actually, just the mid and distal. Yes, we can, Eric.
hear you. How are you?
We're just-
Yeah, good. You know, my take on this
No.
is completely opposite.
And show me the wire.
I think that it's, to be honest with you, it's folklore that people with tibial disease do not claudicate. I've seen many, many, many patients that have severe tibial disease and no other significant disease above that have severe claudication. I think with drug-eluting
do a
coronary
roadmap.
stents,
What do you
you
mean?
could very effectively treat those two anterior tibial lesions in under about 30 seconds, and the long-term patency rate will be nearly 100%, and you may not even need to treat the SFA or popliteal. So I would almost argue that two focal short drug-eluting stents in the anterior tibial artery will alleviate the patient's symptoms.
Well,
Well, Eric, my point to
Miguel.
that is,
this is Amir Motarjami.
Hey, Amir.
Do you know what Eric said right now, that there are patients who have intermittent claudication with distal vessel disease, no proximal disease. That has
Can you
a
take
lot
the-
to do with their
Can you take that roadmap
popliteal
out?
branches. If you have a patient who does not have patent popliteal branches, then distal vessel disease
Roadmap
becomes
off.
symptomatic. But if you have large popliteal branches, those patients don't need any treatment because they get enough flow from the popliteal artery.
You know, I'll say this, if this patient did not have a tibial disease, I don't think will be claudicant. I think this stenosis in the SFA is maybe moderate. And you can tell like the balloon is, I don't think, you know, treating the SFA is going to change his symptoms. I think this is a single vessel runoff, 99% occlusion in the proximal AT. If you don't open that AT, he's not going to get better.
So I think there's one other thing to talk about, and Eric, I understand how you're addressing this. I think fixing the AT is easy and can be done safely and reliably and with an exceedingly low complication rate. But the real question to me isn't whether or not to treat, it's if I treat, how do I prevent that from becoming a restenotic lesion that's going to then not be so easy to treat? You know, so one option is to put in coronary drug-eluting stents, and they're off-label, and there's a little bit of worry about whether that stent will get compressed because it's in a compressible area, and you know it's not a self-expanding stent. But anecdotally, in the cases that I've done, they do work pretty well and they stay open.
I've put in literally hundreds of stents in that location, and they absolutely do not compress right there. Where you get into trouble actually is in the distal third of the calf, because the distal tibial arteries have a considerable amount of kinking that occurs when the foot dorsiflexes and plantar flexes. And so I typically don't stent much below the lower third of the calf, but if you stent in the proximal 2/3 of the tibial arteries with drug-eluting stents, there are absolutely no problems with the stent failing.
I mean, but you know, the data showed that these stents, you know, like they're not 100%, and I think the recommendation is you don't stent unless you have to. You stent if you have a dissection or if you like a bailout. Until now, it's not proven that the proximal part, if you put a drug-coated stent, it's the way to go. I mean, the
Well,
Excel trial
That's
showed that
most of the three trials we have to go on, the drug-eluting stents below the knee have been driven by critical limb selective patients.
Right.
And at the end of the day, the objective of a critical limb ischemia trial is you know, limb preservation. And when you look at the results between balloon angioplasty versus drug-eluting stents, the limb preservation is the same.
right. The
amputation
Excel
rates are
trial
the
showed
same.
that. Yeah.
Yeah, but the Excel
So,
trial was, first of
yeah,
all,
I mean, I understand the patency will be larger and longer, but I don't know if that's what we're trying to attempt here.
The Excel trial, first of all, for people that aren't familiar with that, was a nitinol self-expanding
true.
stent trial in the tibial arteries. There was two issues with that. Number one, that was not a drug-eluting stent. Number two, it was nitinol stent, and those absolutely will
Play the
get
last one.
compressed in the tibial arteries. So the patency rate in that study was terrible, and so that's why that stent's actually been taken off the market right now. It's not even available anymore. But the drug-eluting stent coronary trials that have been done in Europe show patency rates in excess of 90 to 95% at 12 months. And so I personally would not hesitate at all to put a drug-eluting stent in that lesion in the anterior tibial artery.
Jack, what you'll do? What do you do? I know what you do, but you know.
I don't want to be too predictable, but those look soft. I don't think they're calcified. They're short. I think you could do a safe directional atherectomy and never balloon it, and you never stent it. I think they would do very well. And I agree it needs to be treated.
Although this area is very, with atherectomy, sometimes that bend is kind of risky.
Right.
You create some fistula or major dissection. This is
That's the only thing. Are you around the bend enough to be safe? You'd be a little more cautious. Maybe you wouldn't cut very much on the bend.
Yeah, there was.
Miguel, does this patient have any foot symptoms?
It's mainly calf, Amir. It's mainly calf. And so, that's the other thing. Physiologically, the angiosome that goes directly into the calf comes off the sural vessels from the popliteal region. So, moreover, of a reason for, like Luis says, not doing anything. My reason really is not if this is the reason for his symptoms or not. My reason is knowing that any procedure that you do proximally, if you improve the outflow, you know that our results long-term tend to be better. So I don't think that by tapping that anterior tibial, I'm going to cure him. I probably think that by doing just this very simple balloon angioplasty, this guy will probably feel much better. But it's the fact that I would like him to have a longevity of this procedure associated to whatever I do with a better outflow.
I agree with that. I agree with that statement completely. That's been well documented in surgical literature, that surgical bypass graft patency is much higher the better runoff you have. And so I've actually looked at my own data. It's not published, but I've looked at my own data in this, and it's the same type of
roadmap,
same type of outcomes. The better runoff you have, the better patency you'll have for SFA popliteal interventions. This is a single vessel runoff with a suboccluded anterior tibial artery. I think if you leave that alone, it's not going to stay open up above.
I don't think it has any bearing on what's going on above. The most important thing to any bypass graft and viable stent graft is the popliteal artery, the segment of the popliteal artery below the graft.
Where's the tip of the
not
balloon,
necessarily distal runoff.
Where's
We
the
have
tip of the balloon?
many of the viable stent grafts
pass
that
already.
have been
There's one
put
here.
in patients with limb salvage
Keep coming
and
back.
have no patent distal arteries but nice popliteal segment, and
push
they
ahead
remain
now.
patent. And that's one of them was
you
the
take
one
me
I
off
showed
roadmap,
you this
please?
morning. So I think you have to pay more attention to the popliteal artery than distal vessels.
Yeah, that's your tip.
Miguel, this is Tom
Yes.
Davis. This is Tom Davis.
Hey, man.
I have a question for you. Would you, this was a very grungy looking SFA, and I know you ballooned it, not atherectomy, but what do you think the chance of distal emboli with this, and do you ever use a distal protection for balloon angioplasty, the SFA, when you got a single vessel runoff like this?
Yeah, I honestly have this sensation that it is very soft, diffuse plaque. I'm usually more concerned with the more calcified, chunky coral reef-looking plaque. And in this case in particular, other than having a wire protected down the AT as you're seeing right now in this image, I don't believe that I would have done anything now. I hope that you don't jinx me now.
I was trying to get that question in before you shot the balloon.
Oh my God, thank you, man. That's awesome. All right, so let's, guys, I'd like to bring that discussion back again about balloon angioplasty. Do you think it's all said and done? about how fast we should do balloon angioplasty. As what you're seeing here, this is a basket track device. As you know, that's from Bard. It has this other second wire of nitinol that goes on the side, allowing to have pretty much 2 focal points because it's a very short rapid exchange. Creating less dissections. We like it a lot in the tibials. In our practice, we use it widely in tibial interventions. Certainly DCB is going to come and change some of those patterns of interventions. But what's your feeling, knowing that from some of the newest trials where we have a more controlled balloon angioplasty, we're starting to get better results?
The data between, like those old type of balloons and plain balloon angioplasty was negative above the knee. There is no patency, there is no outcome, there is no data showed that those will give you a long-term outcome or patency. I think that's at least what I have. I don't know what the panel thinks.
Miguel, the answer to your question is that this data has been done. It was done in the 1980s in the coronary arteries and in animals before there was ever stents or ReoPro or Angiomax or anything else. And there's definitely a clear relationship towards long, slow balloon inflations and better outcomes, less dissections. Arteries have a viscoelastic property. They stretch when they're gently expanded, but they break and tear when they're not. And the part of the problem is the art of angioplasty has been lost when coronary stents were invented because we just put stents in without a thought process and didn't bother to care about our technique with angioplasty. And so this data does exist. It's 20 to 30 years old, but there's a clear relationship between your technique and your outcomes.
Yeah, I mean, if you look at some of the data, I mean, we unfortunately don't have approved all of the new DCB devices, some that actually didn't make it past the evaluation committee based on some of the flaws that were at least, they're very tight here, and some of the flaws in the data regarding women particularly was one of the reasons why they didn't allow it to go through. But what was amazing about that specific trial was the fact that the results on plain old balloon angioplasty were actually pretty good. So I think that it just shows that when we're biased towards taking the time, allowing adequate slow expansion, we will find results. And we're seeing more people moving that. We're right now starting to enroll on a Latin American trial that's going to be pretty much slow balloon inflation versus drug-coated balloon. And that's the trial is called Que Pasa. And that also has some other implications. Yeah, I know it's cheesy, but I'm from Costa Rica, so.
Miguel, this is Shriniani on the panel. A quick question. If you are prepared to bail out of that popliteal if there's dissection with a stent, and if so, are you then forced to intervene on that tibial?
I'm going to let Luis, what do you, if you're going to...
Well, I just have to state again, I will not treat the tibials, and I respectfully disagree with you, Eric. In my opinion, to see a claudican from tibial disease is exceedingly rare, if not never seen. Claudication is muscle group pain, it's calf pain, which depends, as it was said before, from femoral popliteal irrigation and not from tibial. Tibial disease expresses by either ischemic rest pain or tissue loss. And that's the last thing I'm going to say. Now, obviously, treating the popliteal is something I would do. And if we decide to plasty and that ends up in a dissection, I think we can bail ourselves by a second inflation or a superior stent in that area. In that case, the question changes, as it was properly mentioned, and maybe I will give a little more consideration to treating the AT for better outflow for that stent. But in primary instance, I will not treat the tibial disease just based on the patient's symptoms.
So at least what I'm seeing here, I think we would have to add to that comment, Luis, that we actually have a couple of papers from our group, one particularly on the use of mimetic technology, the superior stent from Abbott, and popliteals having really good results in pretty bad surgical candidates which have no adequate conduit for distal below the knee bypass, and the results have been actually good. So we felt good about that. So I would not have any trouble if in this gentleman I had to do a popliteal stent, knowing that we already have freedom from freedom from TLR at 3 years. Data from Supera being quite amazing and fairly good patency rates at in 7.8 centimeter lesions in the Superb trial at 12 months. So 12 and 24. So let me show that. Ed, can you show me the last one? I like the SFA. I'm honestly not going to treat that. I'm not going to do anything about that. It looks good. There's a very small slight dissection there on the wall. It's not flow limited. I want to see that popliteal area. That right there at the tibial plateau, it seems to be a little on the maybe suboptimal. I might just do IVUS to convince myself if I need to stent it, or I might just retreat it. I was low on the atmospheres. I just did 4 atmospheres.
Miguel,
I
you
might
have 1
just
minute.
do a little more atmospheres. I understand that I have only 2 or 3 minutes.
1
What I'm going to
minute.
do right now is I'm going to create more space into that popliteal area. And then even though Luis is here, we're going to go against his wishes, and we're going to balloon angioplasty those 2 tibial vessels, and then with that we would be done. We'll show you another realm of a little film as how this looked at the end. And I think all the discussion points were amazing, guys. Thank you very much for giving us that time. This was kind of a little more straightforward, but more discussion-driven case. We have a little bit of a nightmare on the third one, but we'll talk about that when that time comes around. Thank you for having us.
Thank you so much. Great case.
No problem, guys. Bye.
All right.
Our next speaker will be Dr. Tipple is going to talk to us about the EXCITE trial, some laser atherectomy in in-stent restenosis.
Okay, thank you to Jaafer again for the invitation to be here. We've already kind of talked a little bit about this earlier this morning, so I'll kind of show you some of the data and give you some of my insight into the trial. The EXCITE trial, it's an excimer laser trial for in-stent restenosis in the femoral popliteal segment. Myself and Craig Walker were the co-PIs. We've already seen that in-stent restenosis is a large problem globally and in the United States, at least 100,000 cases a year, and it's not going away. Whether we invent drug-coated balloons or Viabonds or laser, it doesn't matter. There's millions of people that have stents in, and this is going to continue to be a problem for quite some time. Again, we've talked about this background, but I think this kind of puts it into context, is that the histology, if you look at this, is pretty simple. It's a low cellular environment that has a very high water content, very high extracellular matrix content. And when you dilate this with a balloon, you're simply squeezing the water out of this. This data has been published, this is 10 plus years ago, out of Gary Mintz's lab using intravascular ultrasound in coronary arteries. If you look at, this is kind of a very simple study that we think about doing, but we don't do in our own labs, where you dilate an artery and then you IVUS it before and after, but then you come back 30 minutes later and you IVUS it. Most of us, what we do is we dilate things and it looks good, and we pat ourselves on the back and we go home and think everything's great. But if you look at the curves on the top on the right-hand panel, that's your stent area and your plaque volume, and it really doesn't change. The plaque area doesn't change with balloon angioplasty. On the lower curve, the open squares are your luminal area, and the dark filled-in squares your neointimal area. And you can see in the middle section that immediately after balloon angioplasty, your luminal gain goes up, your neointimal area goes down. But 30 minutes later, you're pretty much back to where you started with, because the plaque simply rehydrates. It reaccumulates the water, and so you've done nothing to the plaque. So we've known that balloon angioplasty doesn't work. So in context, the EXCITE study is really just a historical study to prove that you physically need to get rid of that tissue to make a difference, and that's really what we tried to accomplish. We know from Tasaka and his data that plain balloon angioplasty, again, in the femoral popliteal segment for ISR really doesn't do well. Patients that present with total occlusions have a reintervention rate of over 80%, restenosis rates of over 80%. So once again, trying to point out that plain balloon angioplasty for ISR, it really is not the solution. Anecdotally, this is a case that I did before the EXCITE study even started. You can get nice angiographic results. There's the patent registry out of Europe that again confirmed this, and so that's why we decided to proceed with a randomized trial kind of to definitively say what is the data, even though intuitively I think we knew what the results were going to be beforehand. This was a randomized trial, multi-center trial. There was adjudicated core lab follow-up. There was blinded core lab for ultrasound and for the angiographic events. This is an FDA-approved IDE study, 30-day safety data endpoints, and a 6-month clinical efficacy endpoint. We initially targeted to roll 335 patients, but we had stopping points built in along the way, and we concluded after enrolling about 250 patients that we had met our safety and efficacy endpoints. The randomization was 2-to-1 between the laser angioplasty arm versus the angioplasty alone arm. And we used the Turbo Elite catheter to make a pilot channel, an inline straight channel, followed by the Turbo Tandem catheter, which is an offset laser catheter that when you advance in different quadrants, obviously you can make offset cuts and expand the diameter of the channel that you're cutting through. For those of you that aren't familiar with the Turbo Tandem catheter, this is kind of what it looks like. The radiographic markers, as you make passes, you can rotate it around the face of a clock and again, make a larger lumen through there. When we designed the trial, we designed to make this a real-world type study. I was kind of insistent on making this patients that I saw on a daily basis and not some of the task A lesions that we typically see for these stent trials. But the biggest thing that I wanted to include was no upper lesion length, and you'll see that in some of the data that we had lesions that were over 40 centimeters in length that truly encompass the entirety of the SFA and popliteal artery. The only biggest exclusion that we had was when patients had multiple complex stent fractures, because that's a relative contraindication to trying to navigate the laser through those stent fractures, but minor stent fractures were allowed. This is the baseline lesion characteristics. Again, the average lesion length was 19 centimeters, which if you go back to look at some of the stent data, even the early DCB data, there are task A lesions, 6, 8, 9 centimeters in length. These are much longer than that. A third of them were total occlusions, and 20% of the lesions were over 30 centimeters in length. Again, the entirety of the SFA and popliteal. About 80% of the time, patients had a pilot channel created with the Turbo Elite catheter. Distal protection was left up to the investigator's discretion. It was used in 30 to 40% of the time. When you look at the acute procedural complication rates, again, these are adjudicated by an independent clinical events committee. The laser group is in yellow. The plain angioplasty group is in red. Across the board, when you look at procedural TLR, any dissection, the requirement for bailout stenting, the laser group did statistically better. There was no statistical difference in embolization, acute thrombosis, or abrupt closure. The 30-day safety endpoint, which was freedom from major adverse events, again, favored the laser group statistically over the plain balloon angioplasty group. The primary 6-month efficacy endpoint, again, freedom from TLR, favored the laser group over the plain angioplasty group. These are the Kaplan-Meier curves looking at freedom from TLR. The laser group is in blue. The plain balloon angioplasty is in yellow. This does include patients that required bailout stenting at the index procedure, which was a criticism of the study. So when you removed those patients and looked at it without those and you analyzed it, you still had a statistically significant benefit in the laser group over the plain balloon group. This is from freedom from major adverse events. Again, same type of results favoring the laser group. When we looked at predefined subgroup analysis, really it was irrelevant of what the variable was the age, diabetes status, previous ISR, etc. These all favored the laser group over the balloon angioplasty group. Looking at lesion length, as was just mentioned in the last by Miguel, lesions that are less than 5 centimeters, it really doesn't matter what you do to them. But when you start getting into longer lesion lengths, clearly there was a benefit that was directly related to the therapy. This is something that was, to me, caught my attention. This is the 6-month clinical status. As I mentioned, the primary patency rate and freedom from major adverse events are listed at the top. But if you look down there at that red box towards the bottom, this is what the change in the Rutherford classification was at baseline compared to 6 months. In we tend to think of balloons as being a safe procedure, as an unharmful procedure. But patients had a 7 times higher risk of being worse off at 6 months when the plain balloon was used compared to a laser-only group. And I think that's something important because we're trying to do no harm to our patients by using just a simple balloon, but it actually does make them worse in the long run. So in conclusion of this study, the turbo tandem plus angioplasty is superior to plain balloon angioplasty alone for the treatment of femoral popliteal ISR. This is the first FDA-approved IDE randomized control study that demonstrates the benefit of atherectomy in the lower extremity, whether it was in a de novo lesion or an in-stent restenotic lesion. This led to the FDA approval for this device, and now it is the only atherectomy device that is indicated for the treatment of in-stent restenosis. And I think that just a couple other comments, in conclusion, is that we now have level 1 evidence on how to treat in-stent restenosis. We're beginning to define a treatment paradigm. As I mentioned earlier this morning, a lot of the data up until this point has been anecdotal based on what individual operators do. We also have now approval of the Viabahn for in-stent restenosis. There was a study that some of you may remember that started about 7 or 8 years ago called the Salvage Study. That was actually a study looking at laser debulking plus a Viabahn. For political reasons, that study was terminated after enrolling only about 28 patients. That has nothing to do with the medical outcomes. I think that in combining these, that may be a very good alternative for long-term therapy. And also we've seen some drug-coated balloon data that's been coming out of Europe, the FAIR trial, the Copacabana trial, and so forth. But if you look at some of those studies, there's only 40 to 80 patients. The lesion lengths are 6 to 9 centimeters. Again, relatively short, simple lesions. I think the data is very encouraging. It's promising. And it may be that a combination of therapy of possibly debulking a laser with the laser, a drug-coated balloon, and then a Viabahn may be the ultimate solution. Because even still, with the data that I've shown you today, the outcomes, the TLR rates are not 0 at 6, 12, and 24 months. So I do think that we have not solved this problem yet, and hopefully we're working towards that. Thank you for your attention.
Thank you. Our next speaker is Dr. Skoukas is going to talk to us about the optimal management of Viabahn edge stenosis.
Thank you very much, Asmir and Jaafer, Jack, Amir, all the organizers for inviting me back this year. So let's talk a little bit about Viabahn edge restenosis. Well, the ViaStar trial really was a trial that I think established covered stents as a definitive treatment for very long SFA lesions. This, as you may recall, was a randomized trial of covered stents versus bare metal stents for long SFA disease. And you can see that this was very much a real-world patient population, 19-centimeter average lesion length. Nearly 80% of them were CTOs, task C and D, and 72%. And you can see that at 1 year, the very dramatic differences in terms of efficacy and primary patency between the two groups, particularly for those lesion lengths that were more than 20 centimeters. And this extended out to 2 years where you see a dramatic difference. Only 27% of the full metal jacket bare metal group patients were still patent. However, there is no such thing as a free lunch, and as wonderful as Viabahn is, there is the nudgy problem of edge restenosis, and that really is the Achilles heel of this particular device. But the pattern is very different than bare metal stents. You don't have this long, diffuse proliferative pattern, but rather focal edge stenotic disease. Why does edge restenosis happen in the first place? I think one of the biggest sins that we commit as operators is that we oversize the devices. You can't put a 6-millimeter Viabahn in a 4-millimeter vessel. The Viper trial was a U.S. study to look at the performance and safety of the new proximal contour device with heparin bonding. Again, real-world lesion lengths, 19 centimeters, over 50% of them were occluded, and you can see a very respectable 1-year primary patency rate of 74% at a year. However, one of the things that came back from the independent core lab investigation of the outcomes was the fact that there was significant oversizing in over 30% of those patients. Now, if you as the operator did a good job and you did not oversize the device by more than 20%, you were rewarded with an 88% primary patency rate as a function on the proximal end, 87% on the distal end. So clearly not oversizing the device is very important. The mode of failure for stent grafts, of course, is edge stenosis leading to thrombosis. So let's just dispense right away with one of the myths out there that if a stent graft goes down, it goes down hard and invariably results with acute limb ischemia. That's simply not true. The causes of thrombosis are poor inflow, outflow, edge restenosis, or prolonged extended leg flexion, or patients who don't comply with their dual antiplatelet therapy or who are Plavix non-responders. If you look at the data in both the Viper trial and the ViaStar, each trial had only one single patient who presented with acute limb ischemia as a result of their stent graft going down. The treatment for Viabahn stent thrombosis at this point is pretty well established and pretty standardized. If the patient has acute limb ischemia, then we'll typically treat them with mechanical thrombectomy with TPA, the so-called power pulse spray technique. If they just present with recurrent paresthesias or claudication, we typically will treat those patients with overnight ultrasound-assisted catheter-directed thrombolysis. And then once you clean the clot out, go ahead and treat any inflow or outflow disease and edge restenotic disease. Here's a typical case of a stent thrombosis secondary to an osteal SFA lesion. In this particular case, we basically just placed a 40-centimeter ECOS, treated them with thrombolysis overnight, and then the next day the clot is cleaned up beautifully and you're left with just very short focal edge stenoses, which was treated with a cutting balloon on the proximal end, extended the Viabahn distally, and then with a very nice angiographic result, that patient went home the same day. So we have a lot more options now available, though. We now have drug-eluting stents and drug-coated balloons. So how does this fit into our therapeutic armamentarium for when we do develop Viabahn edge restenosis? It's important to remember that so far we do not have any evidence-based level 1 data. This was a paper that was published earlier this year from the Netherlands. This was a 3-center Dutch study of patients over a 10-year period. With 88 patients, mean time to restenosis was 10 months. 2/3 of these were on the proximal end, 1/3 on the distal end. 58% of the total Viabahn population was with the new contoured device. 41% of these patients presented with acute thrombosis, and the rest were picked up by duplex. Those patients that did present with acute thrombosis, though, were all successfully treated with urokinase, and you can see that 85% of these patients did not present with a cold limb. In this particular study, all 49 patients that presented with acute occlusion were successfully treated with thrombolysis, and then the rest predominantly were treated with plain old balloon angioplasty. About 13% had Viabahn extension, another 19% weren't treated at all, either because they weren't symptomatic or because of renal dysfunction, terminal illness, etc. If you look at what happened to them after the acute treatment, at 12 months there was really no significant difference between the two groups, but there was definitely a strong trend to better outcomes long-term in those patients who were treated with another stent graft. Well, this was an interesting study published earlier this year in the JIC of 10 patients who presented with acute thrombosis where the operators elected not to bother with thrombolytic therapy. Let's just reline the clot by putting in another Viabahn. So they put in 5-millimeter devices, relatively short lesion lengths of about 11 centimeters, and at 12 months on dual antiplatelet therapy, all of these patients were still patent. So let me just go through a few real-life cases. This was a patient who had presented with a long SFA CTO in 2011, ballooned it, placed Viabahns. She did well. About 14 months later, she came back in, and her stents had been closed for a while. In this particular case, we treated her with ultrasound thrombolysis the next morning. Still not clear, so we simply placed a filter distally, did a little mechanical thrombectomy, were able to get that open, and then just did a little cutting balloon angioplasty for the edge restenosis, extended a Viabahn on the distal end, and you can see she had a beautiful acute angiographic result, went home the very next day. Here's a patient who was treated with an experimental biotronic pulsar stent. Unfortunately, a few months later, developed significant restenosis that was treated with a 10-centimeter stent graft, but then 5 months later developed recurrent claudication secondary to a proximal edge stenosis. Treated that with cutting balloon and a short Zilver PTX with a very nice angiographic result. This is a patient who had presented with severe claudication, underwent plaque excision atherectomy, developed restenosis, came back, which was treated with a 5x5 centimeter Viabahn. And then 18 months later, she came back with recurrent claudication secondary to both proximal and distal edge restenosis, treated with cutting balloon, followed by a single long drug-coated balloon with a very nice angiographic result. So this was a very quick and simple treatment. This was a more complicated patient, a lady who had come in with critical limb ischemia with a non-healing hallux ulcer. We traversed an SFA and popliteal occlusion, stented those, but then also treated all of her infrapopliteal disease. She had successful treatment in healing of her ulcer, but came back several months later with an asymptomatic proximal edge restenosis, which we treated with cutting balloon. Weren't terribly happy with that result, so we extended it with a short Viabahn with a very nice balloon. Now, distally, she had a lot more disease. I didn't feel comfortable because of the size of the vessel putting in another covered stent, so we put in a Zilver PTX. You can see there is some disease distal to that, and we did elect to treat that with drug-eluting stents. You know, the Destiny trial was a randomized trial which did show very high primary patency rates with drug-coated stents in the tibial vessels of over 85%, and so we use that here. And finally, let me just share with you a case of a gentleman who I saw in the office just last week. He had had superior stents in 2009. Unfortunately, they developed restenosis in 2010. We treated that with Viabahn stents, and for almost 5 years, the guy had done really well. And then came in last week saying, yeah, you know, I'm having some recurring calf discomfort. We did a duplex, which indeed confirmed that he had had reocclusion of his stents. So we brought him, let's see, today's Wednesday. We brought him to the lab on Monday. You can see that his stents were occluded, but he had excellent runoff distally. So we treated him with ultrasound thrombolysis for about 6 hours, went ahead, did the rest of our cases that day. We brought him back to the lab in the afternoon on Monday, and you can see that he still has some thrombus there, in that he probably thrombosed because of progression of native disease. Interestingly, the Viabahn cleaned up very nicely with just a few hours of TPA. So in that particular case, we placed a Viabahn distally, and then we placed 2 overlapping devices proximally with a very nice angiographic result. And guess what? He went home the same day. So this was a patient that we treated very efficiently and very cheaply with just extending the stent graft. There are some important things to consider, though, to try to prevent it in the first place, and that is to avoid oversizing. It's important to treat all the disease and don't fret about every little collateral. If you're going to treat the proximal SFA, extend the stent graft all the way back to the SFA, treat any concomitant inflow and outflow disease. It's important to post-dilate the stent to get good apposition, but be very careful about not dilating outside the edges. Overlap any overlapping stent grafts by at least 1 centimeter. And I usually will prescribe a full year of dual antiplatelet therapy and perform very rigorous duplex ultrasound. I think that's critical. And even if the patient is asymptomatic, if they develop progressive disease, bring them back and fix it to avoid thrombosis. You've already seen one video about the Mercator Bullfrog device. This is really a very simple but ingenious device that allows you to deliver drug into the adventitia, which is really where the smooth muscle cells hang out. And the DANCE trial is examining the use of dexamethasone to try to prevent restenosis, but we're going to be starting our own trial using Taxol to see if this might be a way of preventing edge restenosis. Here's a case where we did have edge restenosis that we treated with dexamethasone after cutting balloon angioplasty, and 10 months later, this patient is still patent. Another potential option would be to try and treat the edges of the Viabahn with an anti-proliferative drug, and I can assure you the engineers at Gore are furiously working on trying to do this. Another interesting concept is to try to treat the landing zones with DCB. Dr. Zeller and his group in Germany are looking at a strategy of DCB to treat the landing zones, followed by placing a Viabond. So in conclusion, we can say that prevention is better, and if you can prevent edge restenosis, do it. And the best way to accomplish that goal is to avoid oversizing and really use optimal technique. When Viabond thrombosis does occur, no need to panic. It's easily treated with power pulse spray if they present with acute limb ischemia. Otherwise, ultrasound thrombolysis works very well. Once the clot is cleared, it's a simple matter of just treating the edge disease. It can be treated with a number of different ways. And in my own personal algorithm, in the absence of level 1 data to tell us what's the best treatment, in my day-to-day practice, I've basically just been using drug-coated balloon for osteal SFA and for focal edge disease. I think that extending with the Zilver PTX is a very good option, especially if there's dissection or adjacent disease that needs to be treated. And then certainly, oh, you cut me off there on the end.
Yeah, we're...
Anyway, but if there is thrombus, then I think extending the area of disease with a Viabond covered stent is an excellent way to treat that as well. So with that, I will thank you for your attention.
All right, thank you. Our next speaker is Dr. Lopez is going to talk to us about the bullfrog as an alternative to drug-coated balloon.
All right, sorry that this is going to be a little bit of a rerun, but I'll go quickly. So we've all seen this little cartoon now, how the bullfrog is a microinfusion catheter. You inflate a balloon, it punctures the media of the vessel, and you can inject drug into the adventitial area. You deflate the balloon, and the needle collapses back down into the device so that you can move it to the next spot and re-inject. Let's see if I can advance to the next slide. The needle is tiny. It's a 34-gauge needle. It stays constantly inside the confines of that balloon when the balloon is deflated. It comes in 3 sizes, small, medium, large, that you can use in the below-the-knee vessels or the popliteal or the largest one in the SFA. The balloon itself, it only inflates up to 2 atmospheres to try and minimize barotrauma. And you can see in the bottom right-hand corner there that you put a little bit of contrast, 20% contrast, 80% drug into the solution you inject so that you can see what you're doing as you do it, and that's a little time-lapse photograph of a case that we did. Here is a illustration of diseased SFA following, then the next image is the revascularization, followed by the administration of dexamethasone, and then finally the final image after administration of the drug. So we've talked about this a lot today, the mechanisms of restenosis, and one of the things that we do in the lab is we see what is a 2-dimensional representation of what treatment we've administered to the interior of the blood vessel. But what we have to keep in our mind is that what we're actually affecting is the entirety of the vessel, including the media, the intima, and the adventitia. So this is a little slide demonstrating the complexity of the restenotic process, and we know that it's composed of many different things. And Dr. Romani, I thought, did a great job this morning of explaining it all to us and showing that there's essentially 3 segments of the restenotic process. And the first is an inflammatory segment that begins in the first, as soon as we treat the patient, and extends in the first day or 2. Then the second is something that happens more in weeks, and that is the proliferative phase where we see intimal hyperplasia, and then finally the fibrosis and hyperplasia that occurs in the late restenotic process. So drug-coated balloons, we're treating the proliferative phase where we try and eliminate the intimal hyperplasia that can occur, but we have ignored the end phase, which is the fibrosis and hyperplasia, and we're not treating the inflammatory phase, which is at the beginning. So what I submit for consideration is that I wonder if perhaps ultimately what we'll deal with is some combination of therapy where we're injecting perhaps not one drug but multiple drugs so that we can treat both the early inflammatory phase but also the proliferative phase that occurs a little bit later on. At present, we have no treatment for the fibrosis and hyperplasia other than perhaps atherectomy to try and remove it once it occurs. So we're looking at we're currently enrolling in the dance trial, and the dance trial is the first arm is separated into two arms. One is 150 patients that have atherectomy, followed by administration of dexamethasone by the bullfrog. The other arm is 150 patients that have plain old balloon angioplasty, followed by administration of dexamethasone. So at the present time, we're 100% enrolled in the atherectomy arm, 70% enrolled in the balloon angioplasty arm. We're also currently in trial design for the limbo trial, which is essentially looking at the same thing but below the knee, and that's expected to initiate sometime this year. So one of the other things that amongst the things that will be followed is an evaluation of the inflammatory markers. So this, I'll walk you through this slide, but it's, I think, a very instructive slide about what the device does. And in the very first column, when we treat someone with any vascular procedure, you see an immediate increase in inflammatory markers, and that's measuring CRP. And the very first slide shows the typical sort of jump that we see in those markers in people that restenose. If we look at patients that do not restenose, that second column represents patients that do not restenose. So the third column in there, that middle column, then represents what patients look like when they've been treated with atherectomy, the bullfrog device following their intravascular therapy. So it basically reduces the inflammatory response to that of non-restenosers looking at all patients. So that's just a little brief illustration of how biomarkers can be a surrogate for measuring whether or not we're getting effective administration of drug into the vessel wall. All right, so then there's a few practical matters as well. So the bullfrog, it has cost advantages. It's a relatively inexpensive infusion catheter, costs about $1,200 to $1,500. Dexamethasone is cheap. You use 1 or 2 vials for a case. A whole box of 24 vials costs $20. So dexamethasone is an old drug. It's safe. It's well understood. It's relatively low risk. Average lesion length in an SFA, we all know 25, 30 centimeters, sometimes 40. Using a couple of covered stents, there's a hard cost, a dollar cost associated with that. A covered stent is about $3,200. So 2 of them, it adds up to $6,400. If we treat it with 3 or 4 drug-coated balloons, we're looking at almost $4,000 to $5,000, depending on how many balloons you use and what your lab is able to purchase them for. Whereas the bullfrog, using that device plus the drug, is relatively cheap in comparison. Patency rates for drug-coated stents are pretty good, about 70%. We've seen that data presented multiple times. The Achilles heel, as Peter mentioned, is edge restenosis. The 1-year patency rates for drug-coated stents, about 70 to 80%. In a pilot trial, so this is a small pilot trial of the bullfrog, average lesion length was about 9 centimeters, and the patency rates in that pilot trial were about 80%. So we'll see how it looks in a larger trial. One of the things that I think has been danced around, but perhaps not openly spoken, is that when, for one, let me preface it by saying using the bullfrog closes no doors. It's much like balloon angioplasty or drug-coated balloon angioplasty. It doesn't cover the popliteal artery with a stent that then makes surgical intervention, should that ever be required, more difficult. But one of the things that has become apparent to me is that when choosing what modality we're going to treat an SFA with or a popliteal artery and considering anti-restenotic therapy, a lot of us are driven by our willingness to treat the failure mode of whatever that modality is. So if we're using drug-eluting balloons or drug-coated balloons, the restenotic process is actually pretty easy to retreat. You can go in, it crosses easy, it's soft, it's easy to re-atherectomize. If we do a drug-coated stent, when those restenose, I find it a little bit arduous, a little bit laborious to get through an occluded stent. The proximal cap is usually really, really hard. And Miguel Montero Baker did a case this morning where they couldn't get through the proximal cap. So what he had to do is stick a needle into the stent in the mid-SFA and go through retrograde. And it's doable. I've done it. A lot of us have. But it's arduous, right? It's time-consuming. It's lengthy. For covered stents, Viabonds, we've all had Viabonds go down, and they're fixable, and you can get pretty facile at doing it, but it requires putting down a distal filter, lysing whatever is inside the Viabond stent, and then treating the pre and post edge restenosis. So what I have sort of observed in all of the people sitting up here on the panel is that the modality that we use to treat which thing we use to treat seems to be predicated on our willingness to deal with the failure mode of whatever that treatment is. So it's just something to think about, but I would say with the bullfrog, the failure mode is actually pretty easy to retreat. The limitation of the device is that the needle is exactly that. It's a needle, and if you have heavily calcified fibrocalcific disease, you can't get the needle to penetrate. So sometimes you have to move the needle forward, backward, rotate the device around to find an area where you can inject. You give about 1 milliliter of injection every 2 centimeters. Sometimes I'll just throw out that if you have an area where you just simply cannot get the needle to penetrate, I'll go before it and after it and inject double before and after, and it'll diffuse into that area. There'll be occasional cases where you simply can't get through, and that's just how it is. So I want to jump through a lot of these slides because I don't want to go over time, but I want to show you some cases that we've done. Whoops, I jumped too fast. So you can see there's a little staining here. That was my first injection. And do I have to press this to get it to run? I'm sorry there we go. So first you'll see the balloon inflate. So that's the balloon associated with the bullfrog inflating. Then I'll inject, and you see immediate staining of the adventitial tissue. And then you see secondarily a diffusion of that drug outward. And then over time, what you'll see is that drug will also diffuse in a cranial caudal direction and also circumferentially around the vessel. So here is that particular artery prior to treatment. Then I administered the dexamethasone, and you can see how it stains the artery and how that stain sort of migrates circumferentially all around the artery and in a cranial caudal direction. Then I posted it with a balloon, and that was our final outcome. So very reasonable, very pleasing angiographic outcome. This is, I wanted to show you also a below the knee case. There you see the balloon inflating. Sorry, I had a nurse just holding the camera, and she had a shaky hand because I kept yelling at her to hold still. So there's the dexamethasone going in. And then this is in real time. I didn't speed this up. So then you deflate the balloon, you move it, then reinflate the balloon. I wait a few seconds for the needle to penetrate so you can see the balloon inflating there. And then I'll inject again. And you can see it starting to stain. And I'll say once again, even below the knee, whether you're above or below, give it 5 minutes, and then you'll see that contrast stain migrate all around the entire artery. So this is a picture of the artery before I treated. Oops, let's see, did I not hit the button? There is after atherectomy, and then there is the following the final balloon inflation. Sorry, the patient's leg moved a little bit, and I did the best I could to adjust it. So in conclusion, bullfrog, safe device to use, easy device to use. Preliminary results look good. We have major trials that are in progress, and we should have more definitive data coming later in the year. Does not close any doors, and it may be viable as a standalone therapy, but it may end up being an adjunct to drug-coated balloon angioplasties to get us past that last 20% to get really excellent long-term patency results. I thank you for your attention.
Thank you. All right, Jack. Dr. Shambo is going to lead some discussion regarding atherectomies and
and when you use it in your practice.
Yeah, I think we really should just go up and down the tables here and talk about this. I think that what I've been struck by this morning watching the maturity of over the last 5 years of our conference is how drug-coated balloons, drug-coated stents have went from a novel future thing to now we have a whole morning here we've been talking about it. I wonder if I could just go down the line here for people kind of talk about their use of atherectomy in the past versus in the current state, and has it changed for you? Mr. Irvin?
Absolutely. I'd like to just comment first and foremost to the panel, and a question actually really, is there any case that you would not use a filter in when you're atherectomizing? Because it's amazing the transformation of these meetings in the last 3 years. It seems now the standard of care is utilizing a filter, even though, as mentioned this morning, there is no dedicated filter for any atherectomy device. So I'd just like to pose that question really quick to the rest of the panel.
Yeah, my 2 cents on that is that if I can get a filter in, I'm going to use it, and that's that simple. I mean, the problem is sometimes when you get into the very distal tibial arteries and the small vessels, the filters just don't go down there, they don't sit well, but that's really the biggest problem.
I'll give my 3 cents on it. And Eric and I argue about this all the time. I think if you look at the data on all the atherectomies when they've been trialed, very few of them had used distal protection, and there was a very limited amount of distal embolization that was clinically relevant by angiographic core labs. So I don't use them in all cases. I use them in some. I think if it looks like, as I call them, mobile plaque elements, more shaggy, like we saw Miguel do that one, sort of like grungy material, or if it's very calcified, certainly I think those are going to be more potential mobile, but I choose and pick and choose who I'm going to use it on now.
See, I just want to follow up with what Tom said, because that's like wearing your seatbelt on the highway and not wearing it in town.
I agree with Eric. You know, I have migrated more and more to using filters more and more frequently, and as careful as I can be, I don't think I've ever done a case where I had 0 in the filter, and I can't imagine any circumstance under which that having gone downstream into the distal vascular bed is somehow good for the patient or the foot.
Well, I use distal protection very routinely with all atherectomy that I do, with Silverhawk, and all the angiojet thrombectomy I do. I don't use it for laser, and if my runoff is a single vessel runoff, then I put a 3 millimeter distal protection into tibial arteries if I have to go down to the popliteal. But I certainly put distal protection, not only because of patient's sake, because of my own sake. Otherwise, you have to spend a lot of time trying to retrieve a distal embolization. I agree with Derek 100% as far as nothing against you, by the way.
Listen, I've seen you guys drive out of your driveway with helmets and strapped into your cars incredibly, so I'm not worried.
I wrap myself in bubble wrap every morning.
You know, I think I use atherectomies in Silverhawk or like the Turo, but I'm not sure why you want to use atherectomy if you're using CSI. I mean, I think even like I think those particles are too small. I don't think it causes problems. And if you have, I think the filter by itself can cause damage too. I mean, you know, I mean, you've seen like complications with filters. So if a patient has a 3-vessel runoff, probably I'll get away without filter.
Yeah. Yeah, I think that I think that's, to me, that's the biggest thing, is what's their runoff and what is their what's the clinical scenario. If they have critical limb ischemia and you're going to use any device, I would really try hard. And I think the issue, as Eric brought up, is if you can get it there. 'Cause a lot of times you're trying to drill things that are way downstream, and it's quite challenging. But you can get debris absolutely from any device, and even things that say they suck out the device. You put the filter down, you'll get a lot of stuff. So. Any thoughts, though, about drug-eluting technology? Has it changed your approach with atherectomy? Do you use less or more or combined? What do you guys do?
I would say I've definitely made more of a conscious effort to try and put less stents in. I haven't gone away completely for stenting because I do think they're beneficial. But I think that if you can get a reasonable result without one, I'm less likely to put a stent in.
So you're down to what, just 90% now?
Yeah, 99.
You know, I think, at least I'll talk about my practice. and I hear it from a lot of people, drug-coated balloon is taking a little bit of the atherectomies away, especially not like in the atherectomy zone. Like if you have a diffuse SFA, you might get away with just like putting a 5/0 drug-coated balloon or two of them, versus like different, maybe if you don't want to stent like a common femoral or a popliteal, probably I still do atherectomy. But I think with the European don't do atherectomies. They don't get paid for it. They don't do it. They believe in drug-coated balloon, and they've been doing this for a long time, and the results are almost like 80-90% in the first year.
All that said, like if you look at the data that we looked at today with Zeller, for short, simple lesions, yeah, anything works. So short and simple lesions, you can do whatever you want. But the lengthier lesions, atherectomy followed by drug-coated balloon shows significant improvement. If you look at heavily calcified lesions, atherectomy first followed by drug-coated balloon is clearly a better strategy.
Yeah, I think that's what's kind of, I thought it was kind of funny earlier when McKinsey was talking about, if he's still in here, about long discussion about drug-coated balloon, and in the end, his conclusion was using it in every place it hasn't been studied. And that's what we all do. We use drug-coated technology in the worst lesions, and I guess that's my worry, is that it's not a panacea, and I think we can't forget that we probably should debulk some of these people, and especially with calcium. So, any other thoughts on that, folks? Dr. Starr, any thoughts?
I just want to say back to the whole discussion about atherectomy. I'm a surgeon, so I'm pretty conservative about what I use and what I tackle. And my place for atherectomy is mostly behind the knee, where I don't want to stent it, and I don't want it to fall apart, because then I think you've got less options. And then I don't tackle either those big exophytic sort of chunky calcium load through the whole SFA and popliteal. Those scare the bejeebers out of me, being a surgeon, because I know what they look like on the inside. So that may be why I don't use a lot of distal embolic protection. That, and when you have two vessels, I never know which one to choose. I guess the more important one, but it's like, which child do you want to save off the bus? So that's sort of my place for atherectomy. Regarding DCB, I don't know when to use it. You know, now that it's been approved, you know, the hospital wants to know, well, who are you going to use it in? You know, everybody, nobody, you know, and like you said, it's usually the worst case scenario. So I don't think I've figured out, and I'd be interested to hear how people are deciding who to use it in. Is it the recurrent lesions? Is it women? Is it people with calcium, diabetes?
Anybody using it on label? Just asking. I just want to know.
You know, they changed the code now. You actually charge for the first one, and after that, the second and the third one, you know, like the hospital, it's not a problem. They pay for it. So that's why, you know, it's not a big deal anymore. You can use 3 of them in one vessels, and
it's not 100% though. It's not 100% coverage on the second and third one. It's a percentage, and I think it depends on your contract too.
You know, the thing you have to keep in mind is, as wonderful as drug-coated balloons are, at the end of the day, it's still a balloon. With all of the shortcomings inherent with balloons, namely dissection and elastic recoil, and areas where we don't want to put a stent in, it makes perfectly good sense to try and deal with that lesion with atherectomy and then finish up with a drug-coated balloon to give you that hopefully better long-term patency. So particularly for the so-called no stent zones, behind the knee, osteal profunda, osteal SFA, common femoral, it seems to me that that those technologies are really complementary, and you would want to use them in combination, and that probably is going to result in a lot fewer stents needing to be implanted.
Well, also, I just want to add in about Pete, you had a great point in your slides. You were using cutting balloon, and Miguel mentioned that as well. It seems to have fallen by the wayside in popularity significantly since DCBs have come out. So I think that has a place to play still in this kind of situations that we are in for those tough calcified lesions where you know the DEB really is going to penetrate that well.
Well, I think the bottom line is you still need to prep the vessel well. And you've seen in the Medtronic trial where they had a significant amount that were just with balloon angioplasty did not get prepped well, and they didn't even enroll them. So I think atherectomy in those cases, especially as people have been saying, places that you don't want to stent, that you want to avoid it. I think atherectomy and drug-coated balloon is an excellent choice in that area, and I use it quite a bit in, you know, popliteals and especially. So I think we'll learn more as more studies are done in that sense. But I suspect that that's going to be it's going to be a great way to prep the vessel for drug-coated therapy.
I think it's going to be used now more often drug-coated balloon, because a combination of two might be something that would be very helpful, especially in long segment disease.
So Eric, is the PhotoPack trial ever going to happen?
Well, I mean, the PhotoPack study, the pilot study has been done in Europe, and the one-year data looks excellent. It looks fantastic. It will probably be done in the United States, but it's going to be a little ways off, and there's political reasons for that, but that'll probably happen for sure. Yeah. But I mean, going back to, you know, some of the comments, and I mentioned this in my lecture, is there's not one device out there right now, no matter what it is, where the TLR rate is 0. And patients don't want to come back. They want to be cured. They want you to wave their hands and you fixed them and they don't want to come back. And so I don't care what device you choose. I haven't found one that works perfectly every time. And so I think that we get into these debates and these panels about one device over another. But I'm a big fan of combination therapy. I think that use product A, B, C, and D all at the same time works great because and I think there's incremental benefit to that. And until we find a perfect solution, we still have a long ways to go.
All right. Mo, yes, go ahead. I have to talk loud. Wait, this mic. There we go.
I heard earlier that in areas like common femoral, profunda, and popliteal, the stents were used. What is the panel's opinion? Would you use it as a bailer, or can we use a supera stent in those regions, like as a choice? I want a clarification.
Can I answer that as a surgeon? Don't do that.
Yes.
I'm sorry.
Please try not to.
Earlier,
I know
that's
it
why I
looks
want
good.
clarification.
Yeah,
But I will be cussing your name the day I operate.
So any other
I just
comments?
want to reply to that because I'll go back to the comment that I made this morning. If you have a surgeon, then I think that's a respectable answer. But I practice in a place where I don't have really any surgical coverage. I practice where I send patients to the surgeon and they refuse to do them. And so in my situation, it's 100% endovascular therapy for everything. And so I think it really depends on the colleagues that you work with. If you have a surgeon that you work with, that you get along with, and you guys have a good relationship, then I think a simple common femoral end arterectomy is a fantastic operation. But if you work in a place where you don't have that option, then you're going to have to figure out something else. And I think a superior stent works very well in that situation. I've put in many of them. So I
Yeah.
think it's variable, and I don't think that it's a difficult answer.
I would say
All
the
right.
biggest thing is to have a collaborative discussion with your surgeon.
Well, you know,
Look at the pictures.
there is no uniform situation. What works for one patient might not work for the other patient. So you have to evaluate every single artery by its own merit. If you have a very small popliteal artery, I don't care what you do to it, it's not going to stay open that long. And your popliteal artery has a focal lesion, has a diffuse lesion, so that makes difference. But usually combination of atherectomy, angioplasty, if needed, we try not to put stent in popliteal artery. Probably most of my popliteal artery disease is treated with atherectomy and angioplasty. Now, from now on, it's going to be
Okay.
atherectomy and drug-eluting balloon.
Time to go on?
Right.
But
Come on.
I try not to put
Perfect.
stent in. But
Sorry,
sometimes
Dr.
you have no
Jaafer, I
choice.
have to, we have to keep moving. Great. Dr. Davis is going to talk to us about a new technology, of a new atherectomy device that's out there. Thank you.
I'm always worried about interrupting Amir because I know I could be somewhere in the bottom of the Chicago River by doing that. So that's why I was very quiet. That's why I was very quiet over there. That's why I was very quiet. Anyways, we're going to be talking about two new atherectomy devices, Phoenix and Pantheris. Phoenix has been recently approved by the FDA. We'll talk about that. And Pantheris, which the study is just recently finished, and hopefully we'll have some data coming up. It's my disclosures. So let's talk about the Phoenix atherectomy catheter first. As you can see it there, it's a very simple catheter. It's a single insertion, single operator. It's an over-the-wire device. It's got a battery pack that snaps on, and it has the catheter itself has the blades at the tip, and it also has a bag that will go on the back end that you attach to to collect material. So there's no capital equipment, very simple, very easy to use from all that standpoint. The features of the Phoenix, as you can see, it's got 2 blades and it's front cutting. So typically you would not have to pre-dilate to get this by there. It's got 2 blades that actually act like scoopers, ice cream scoopers. If you ever do that to scoop out the ice cream in a box. And then it's got a series of blades in the back that will emulsify it. And then what it has is it has this Archimedes screw that comes up the shaft, and the debris will then be brought passively back through the shaft out of the catheter. So it certainly has benefits of helping reduce distal emboli with that, and and as I said, front cutting aspects of it to get through most lesions. This is the Phoenix catheters. It starts 1.8, which are usually the 5 French and usually for tibial vessels, 2.2 for popliteal, and 2.4 with a deflecting. This is going to be a new device. It's coming out. It's not there. It actually has a deflecting sheath, which will actually, from the 2.4, can get up to a 7 millimeter vessel. I've actually seen it in Germany. Dr. Zeller used this on a iliac and instant restenosis, as we've talked about, and amazing what it was able to do. But it's got a variety of ability to treat SFA, popliteal, and infrapopliteal vessels. This is a case by Rich Kovac, who, as you can see, the diversity of the catheter. This is a severely stenotic, very calcified SFA. As you can see, the Phoenix catheter coming down through there over the wire. Again, it's a slow pass, same thing as laser, because again, the debris that's coming up there can only go up so fast. These blades spin about 10 to 12,000 RPMs, and so about 1 millimeter per second advancement is what's recommended. As you can see, after the Phoenix catheter, fairly reasonably good result from an atherectomy standpoint. And then after balloon angioplasty, a very nice outcome with the combination therapy. So the clinical data from the Phoenix trial, this was the EASE study. Myself and Dr. McKenzie were the PIs. It was an IDE. It was a safety trial mainly to get for the IDE study and approval for the device. So as you can see, there was a total of 123 lesions that were treated. The distal size was about 3.5. Most of these were infrapopliteal and popliteal. Lesion lengths were fairly short. Again, safety trial, so not a lot of there was a lot of cases that fell out because of heavy calcium and lengthy lesions. Pre-treatment with PTA, as you can see, was very low, so the front cutting aspects, this actually was one case that the device underwent a redesign because the housing came outside the blades. Now the blades come outside the housing, so that shouldn't be a problem anymore. You can see that the bubble wrap was not used in this case on any of them, much to Eric and Amir's chagrin, I think. Bailout stenting was very low, and you can see the handle run times there. Above the knee was roughly half the patients, below the knee as well. Most of them were popliteal and infrapopliteal vessels. You can see the inclusion was Rutherford 2, 2 Rutherford 5, with a fair amount of them being a third of the patients being Rutherford 5 and 4. This is a case, one of the first cases done in the EASE trial. You can see initially both the anterior tibial and perineal trunks being totally occluded. The perineal was treated with balloon angioplasty alone, and then Phoenix was used to treat the anterior tibial as a standalone device, and very, again, nice results. You can see the primary endpoints, 95% technical success with the device, which exceeded the performance goals. 30-day MAE, where there was 6 of them for 5.7%. And meet the target performance goals. You can see there was clinically driven TLR at 30 days, 1 patient. Perforations, there was 1 distal emboli and 3 unplanned toe amputations. So fairly safe device as compared to other atherectomy trials out there. No problem. In your CLI versus your non-CLI subgroup analysis, you can see the technical success rate was a little bit lower in the CLI, again, a much more difficult patient base to treat. The MAEs were a little bit higher than that, but again, a fairly good number. At 6 months, most of these were target lesion revascularizations, but 18% and 16%, as you can see, and the freedom from target lesion revascularization is 6 months. And that was clinically driven, and then the target vessel lesions. So fairly durable, at least in this small subset study. If you look at above the knee and below the knee groups, again, technical success rate was good in both. MAEs were fairly low in both groups, and at 6 months, again, the target lesion revascularization was fairly low, so in the below the knee. So again, a good catheter, I think, for popliteal and infrapopliteal lesions per se. So that's that briefly. Now I'm going to give my rest of the half of the talk for the Pantheris catheter. As you can see here, this is a device that's just recently been, the study was completed. It's in follow-up. It's not FDA approved as of yet, but as you can see, it's an OCT, optical coherence tomography catheter, so you can actually visualize what you're cutting. It's directional. What it has is a blade that opens up from the handle, a balloon that's behind the cutting edge, and that gets inflated with CO2, so it's a rapid inflate, deflate, and then you advance it as you would any directional atherectomy catheter. So this is the images that you'll see. As you can see, there's a when you're looking at OCT on these things, you're really looking at layered structures, and that's what you want to stay away from, because that's your media, adventitia, and external elastic lamina. So those are the things that you want to stay away from. You want to be cutting disease. Disease can be multidimensional in the way it looks on OCT, but the layered structures that you will see, meaning media, are really distinct. This is sort of a image-guided aspect of how this device works. You can see that as the cutter gets pulled back, you can advance the cutter, and then the balloon inflates behind it, causing an urge into the lesion, and again, rapidly cut. And as on the lower side, you can see actually the debris that you're cutting, and you can actually see where you're actually cutting with this. Again, pointing it away from media and adventitia and really going into the disease, which is almost always going to be eccentric, especially on total occlusions as you pass them. Now here's this is as I mentioned here. So the device, the blade is to 5 o'clock to 10 o'clock there. The back where the balloon is on the opposite side. As you can see, that is the media and EL, and that's, again, very distinct when you're looking at them. So you can cut away from that area, and you can, as well, you can stop as you're cutting through there. This is the case. As you can see on the right-hand side, they're scanning this, and so the cutter is actually closed. So you can move this up and down, rotate around, and look where the disease is. And this is really, you don't really see any layered structures till you get here. And so you can actually point the catheter to the opposite direction and see. And if you look at this, this is a post-atherectomy device case. And now we have the cutter opened up, and you're rotating it around. Oops, went too fast here. Sorry. Now the cutter's opened up, and you're actually pushing the catheter in and cutting debris. And as you advance it, and you can see as you're cutting through here, you're going to see now, see where up there you see layered structures where you're going to stop cutting. So that's the whole concept of it. You don't want to hit the normal peering portion of the vessel. Moving forward. As you can see, this is a total occluded vessel, the SFA, and if you look at the right-hand post-Pantheris catheter result, you'd say you really did probably cut a lot of media and adventitia potentially out of there. It looks like it was overcut if you were going to be doing an atherectomy patient. And this is the tissue specimens that came out of that atherectomy device. But if you look at the actual tissue histology, there was about 3% media, no external elastic lamina noted in there whatsoever. So this was really all plaque that was in that vessel. The vessel is more diffusely diseased as we look at it. So very, very successful in terms of actually cutting out true plaque rather than the media itself. So in conclusions, these are two new atherectomy devices. I think that offer different unique benefits as to other atherectomy devices out there. The Phoenix device, it really is over the wire, so it has rotational aspects. It also has directional aspects with the sheath that direct this catheter to a larger size, similar to what the laser does. But it also has removal of debris, which is a passive amount. There's no aspiration to it, no capital equipment, no difficult setup. So I think that's unique in that aspects. And I think will be actually very good for tibial and popliteal vessels and potentially OBLs out there because the inexpensive catheter. And the Pantheris, I think, is going to certainly be the only catheter out there that has visualization and the ability to limit damage to media. And certainly this is the other thing I think, limit radiation exposure. You can do, as you get better at these procedures, you can really do this without looking and having fluoroscopy on. And I think that will be a huge benefit as we learn more about cancers and things that are caused by occupational hazards. So thank you.
Thank you, Tom. Appreciate it. All right, our next speaker, Dr. Mutarjami, is going to talk to us about FEM and POP aneurysm and management.
The Phoenix atherectomy looks like old tech,
But
isn't it?
It doesn't have the aspiration.
Yeah,
the
but
doesn't have the aspiration.
Okay. Where's my? It didn't work. Can you put my slides on?
You're losing time, Amir.
I am. Anyhow, popliteal. Okay. Popliteal aneurysm is the most common aneurysm of peripheral arteries, about 70%, and almost exclusively happen in men. It's very rare in female. 50% of the popliteal aneurysm are bilateral, and if you have unilateral popliteal aneurysm, you have a chance of about 40 to 75% to have aneurysm other areas. If you have a bilateral popliteal aneurysm, your chances are 68 to 87%. Etiology of it, 90% of the popliteal aneurysm are due to atherosclerosis. The other 10% is popliteal artery entrapment, trauma, and infection. The symptoms, 30% of them are asymptomatic, 30% of them come because of claudication, 25% with resting pain, 5% ischemic ulcers, and 10% of the patient with aneurysm complain of pain due to compression symptoms. But popliteal aneurysm, patients usually don't come with a patent popliteal aneurysm. Most of the patients come when the popliteal aneurysm is thrombosed. The symptoms, again, is claudication or acute ischemia of the foot. Treatment, all treatment, and still probably one of the best treatment is bypass surgery, but thrombolysis and endograft can be used for treatment. Patients, there are several publications about the thrombolysis in thrombosed popliteal aneurysm. Patients who have thrombolysis then have bypass surgery have a lower amputation rate, and the reason for it is improved preoperative runoff and also unmask the aneurysm and makes the surgeon being able to plan that for surgery better. I've treated 14 patients with thrombosed popliteal aneurysm. 13 of them were due to atherosclerosis, and one of them was a popliteal entrapment in a Navy officer. The symptoms, again, claudication. 5 out of 14 that had claudication, 35%, and 9 out of 14, 65% as CLI. The way they were treated, thrombolysis and PTA in half of them, and the other half thrombolysis, then endograft. The success rate was 100% except for one patient who we couldn't save his leg and had to have amputation. Complication that was done, one was amputation and one had distal emboli, which was successfully removed, and one had hematoma. This is an example of a patient who came with acute ischemia of the left leg, 87-year-old. And after thrombolysis, that was his aneurysm. And usually when you have thrombosed popliteal aneurysm, you always have a very tight stenosis distal to aneurysm, as this patient had it down here. You can dilate those and make the leg functional until either you make a decision of doing a bypass surgery or endograft, or in this case, this patient refused any type of the surgery after we got his aneurysm open and it was going okay. And he did very well, except that he came back next year with thrombosis of the other popliteal artery. And that was the left side that was dilated with that stenosis and made that popliteal less symptomatic. He came back with thrombosis of the right side. As you see, we did a lytic therapy. We dilated that stenosis. That was wall graft, and we put wall graft in him. One of the problem with the wall graft was after a while they shorten because they expand and they become shortened, and that's exactly what happened to this patient. His aneurysm was uncovered, so we went in and put another extension to that. And wall graft didn't do very well in popliteal aneurysm, and the reason for it is that it was a pretty stiff endograft. When patient bend the knee, it occlude the graft. This patient had a re-thrombosis after 1 year that we had to go and open it again because he was refusing having any type of the surgery. And he finally died at age 91, but he did okay with his leg. This is a case of the multiple aneurysm. Patient has a AAA and had, as you see, it had aortic bifurcation graft. Then I had the popliteal aneurysm which thrombosed and he lost his leg. And then he thrombosed the left bone and they told him that he needed another amputation. This was out of state. When a patient came to me, that was the way you see it, as an ischemia of the leg, and I treated him with echoes, and then after treatment, there was enough lysis that I was able to cross the aneurysm, get down below the knee, and find a landing zone below the knee, and put a graft in it, a stent graft. And as you see, here is the landing zone below the knee, and here is right above the aneurysm that we and masked. And then you see the wall graft. I'm sorry, not that's wall graft. That's Gore's graft, Viabon. And now you can see that he really has 3-vessel runoff. The flow was extremely, extremely slow, but he gradually did very well. And this ultrasound was done, I believe, in March. And this year, after 5 years, and that is still patent. And as you see, as a triphasic waveforms in his popliteal area and good anterior tibial runoff. That's his PTA at the angle and his dorsal speed. So he's doing extremely well. This is a patient who already had a stent graft which thrombosed, then went and had the saphenous vein bypass graft. That one also thrombosed, and now he had severe claudication. So I thought I might be able to go and get his the vein graft open, because there was no way to do anything further with his aneurysm, with his graft, because the surgeon, when they do this bypass surgery, they tied, most of them, they tied the aneurysm, the artery above the aneurysm. So I did the lytic therapy, but unfortunately, just put a catheter right into the graft, and he didn't respond to lytic therapy. Most of the vein graft don't, because they don't occlude because of thrombosis, because of very bad disease, venous disease. So, but I was able to go through that and dilated the vein graft. As you see, middle of the vein graft had a leak there because it was a very bad vein, and dilated. I finally put a Viabon stent graft throughout the vein graft, and as you see, it did very well. You can see the other Viabon next to it. He did very well for 2 years, then he died unrelated to his aneurysm. In conclusion, although saphenous vein is still probably the best treatment for popliteal aneurysm, but there are a lot of articles in literature that show that Viabon stent graft practically has the equal patency rate and success as saphenous vein. Thank you very much.
Thank you. All right, thank you, Dr. Mutarjimi. So what we're gonna do now, we're gonna break for 10 minutes, only short break. You guys can go get some snack, coffee, and come back in 10 minutes. Also, we appreciate our sponsors, so I'd like you to visit the sponsor outside. And remember, we have a reception between 5 and 6 today. It'll be great if you guys stick around. We'll love to have you all here. Thank you.